All cells and tissues need oxygen to live and function. Some cells, such as brain cells and heart muscle cells, are very dependent on oxygen. Without oxygen, brain cells stop functioning and die in about 5 to 10 minutes. Other cells, such as skin cells, can live and function for many hours with low oxygen levels or even without oxygen. Skeletal muscle cells can survive for hours with low oxygen, but cannot function for long without it. Any respiratory problem affects total body health and well-being. Lung and breathing problems are common and are the 5th leading cause of death in North America. Some respiratory problems are chronic and the patient has physical and lifestyle limitations. Many acute health problems, medical therapies, and surgeries adversely affect respiratory function temporarily or permanently. The source of oxygen for all body cells is the air we breathe into our lungs. Delivery of oxygen to the cells and tissues requires the pumping mechanism of the heart and the oxygen-carrying mechanism of hemoglobin in red blood cells. In health, the need of body tissues for oxygen is balanced by the body's oxygen intake and delivery systems. The system includes the upper airways, lungs, lower airways, and alveolar air sacs. Air with oxygen enters the nose and mouth and moves through the airways or respiratory tubes, which include the trachea, bronchi, bronchioles, and into air sacs or alveoli of the lungs. Once in the air sacs, the oxygen moves into the blood so it can be carried to all tissues and organs. Carbon dioxide, the waste gas created in the tissues, moves from the blood into the lungs so it can be exhaled. The respiratory system is important for oxygenation and tissue perfusion because the source of oxygen for all body cells is the air we breathe. The purpose of breathing are, first, to provide oxygen for tissue perfusion so that the cells have enough oxygen to metabolize and generate energy, and secondly, to remove carbon dioxide, the waste products of metabolism. The respiratory system also influences acid-base balance, speech, sense of smell, fluid balance, and temperature control. The lungs are also an excretory organ because they can also break down some toxins and eliminate them from the body during exhalation. The nose, made up of bone and cartilage, is divided into 2 nares by the nasal septum. The septum and the internal walls of the nasal cavity are lined with mucous membranes that have a rich blood supply. The nares are lined with skin and hair, which helps keep particles or organisms from entering the lungs. The tuberants are 3 bones that protrude into the nasal cavities. The tuberants increase the total surface area for filtering, heating, and humidifying inspired air before it passes into the nasopharynx. Inspired air entering the nose is first filtered in the nose. Particles not filtered out in the nares are trapped in the mucus layer. These particles are moved by cilia to the throat, where they are either swallowed or expectorated. Inspired air is humidified by the mucous membrane and is warmed by the heat from the vascular network. The internal nose opens directly into the sinuses. The paranasal sinuses are air-filled cavities within bones that surround the nasal passages. Lined with ciliated membrane, the purpose of sinuses are to provide resonance during speech and to grease the weight of the skull. The pharynx, or throat, is a passageway for both the respiratory and the gastrointestinal tract. The throat is divided into the nasopharynx, the oropharynx, and the laryngopharynx. The nasopharynx is located behind the nose above the soft palate. The eustachian tubes connect the nasopharynx with middle ears and open during swallowing to equalize the pressure within the middle ear. The oropharynx is located behind the mouth, below the nasopharynx. It extends the soft palate to the base of the tongue and is used for breathing and swallowing. The palatine tonsils, which are part of the immune system, are located on the oropharynx. The tonsils guard against invading microorganisms. The laryngopharynx is the area located behind the larynx, extending from the base of the tongue to the esophagus. It is the critical dividing point where food and fluids are separated from the air. At this point, the passageway divides into the larynx and the esophagus. The larynx is the voice box and is located above the trachea, just below the throat at the base of the tongue. The larynx is composed of several cartilages. The thyroid cartilage is the largest and is commonly known as the Adam's apple. The cricoid cartilage, which contains the vocal cords, lies below the thyroid cartilage. The cricoid membrane is located below the level of vocal cords and joins the thyroid and the cricoid cartilages. This site is used for emergencies for access, such as a tracheostomy, to gain access to the lower airways. Inside the larynx are two pairs of vocal cords, the false vocal cords and the true vocal cords. The glottis is the opening between the true vocal cords. The epiglottis is a leaf-shaped elastic structure that is attached along one edge to the top of the larynx. Its hinge-like action prevents food from entering the trachea, known as aspiration, by closing over the glottis during swallowing. The epiglottis opens during breathing and coughing. The lower airway are the trachea, two main stem bronchi, lobar, segmented, and subsegmented bronchi, bronchioles, alveolar ducts, and alveoli. This system of branching tubes, which decrease in size from trachea to the respiratory bronchioles, allows gases to move to and from the lungs. Gas exchange takes place in the lung tissue between the alveoli and the lung capillaries, not in the airways. Trachea or windpipe is located in front of the esophagus. The trachea branches into the right and left main stem bronchi at a junction called the carina. The trachea contains 6 to 10 C-shaped rings or cartilage. The open portion of the C is the back portion of the trachea and contains smooth muscle that is shared with the esophagus. The main stem bronchi, or primary bronchi, begin at the carina. The bronchus is similar in structure to the trachea. The right bronchus is slightly wider, shorter, and more vertical than the left bronchus. The main stem bronchi branch into secondary or lobar bronchi that enter each of the 5 lobes of the lung. Each lobar bronchus branches into progressively smaller divisions. The bronchi are lined with a ciliated mucus-secreting membrane. The cilia move mucus up and away from the lower airway to the trachea, where mucus is either spit out or swallowed. The bronchioles branch from the secondary bronchi and divide into smaller and smaller tubes, which are the terminal and respiratory bronchioles. These tubes have a small diameter, no cartilage, and depend entirely on the elastic recoil of the lung to remain open. Alveolar ducts with alveoli attach branch from the respiratory bronchioles and resemble a bunch of grapes. Alveolar sacs arise from these ducts. The alveolar sacs contain groups of alveoli, which are the basic units of gas exchange. A pair of healthy adult lungs has about 290 million alveoli, which are surrounded by lung capillaries. These numerous small alveoli share common walls, making a large surface area for gas exchange. The alveolar walls have cells called type 2 pneumocytes that secrete surfactant, a fatty protein that reduces the surface tension in the alveoli. Without surfactant, atelectasis occurs, and gas exchange is reduced because alveolar surface area is reduced. The lungs are elastic, cone-shaped organs located in the pleural cavity in the chest. The apex of each lung extends above the clavicle. The base of each lung lies just above the diaphragm. The lungs are composed of millions of alveoli and their related ducts, bronchioles, and bronchi. The right lung, which is larger than the left, is divided into 3 lobes: upper, middle, and lower. The left lung, which is narrower and smaller, is divided into 2 lobes. Any problem with the right lung interferes with oxygenation to a greater degree than a problem in the left lung. The pleura is a continuous smooth membrane composed of 2 surfaces that totally enclose the lungs. The parietal pleura lines the inside of the chest cavity and the upper surface of the diaphragm. The visceral pleura covers the lung surfaces. These 2 surfaces are lubricated by a thin fluid produced by the cells lining in the pleura. This fluid allows the surfaces to glide across each other smoothly and painlessly during breathing. Blood flow to the lungs occurs through 2 separate systems, bronchial and pulmonary. The bronchial system carries blood needed to meet the metabolic demands of the lungs. The bronchial arteries, which branch from the thoracic aorta, are part of the systemic circulation and do not participate in gas exchange. The pulmonary circulation is a highly vascular capillary network. Oxygen-poor blood travels from the right ventricle of the heart into the pulmonary artery, which eventually branches into arterioles that form capillary networks. These capillaries are meshed around and through the alveoli, the site of gas exchange. Freshly oxygenated blood travels from the capillaries to the pulmonary veins and then to the left atrium. From the left atrium, oxygenated blood flows into the left ventricle, where it is pumped throughout the systemic circulation. Breathing occurs through changes in the size and the pressure within chest cavity. Contraction and relaxation of specific chest muscles and the diaphragm causes changes in the size and the pressure in the chest cavity. Accessory muscles that help in the process include the scaling muscles, which lift the first 2 ribs, the sternocleidomastoid muscles, which raise the sternum, and the trapezius and pectoralis muscle, which fix the shoulders. At times, various back and abdominal muscles are used when the work of breathing is increased. The respiratory changes that occur with aging include alveolar surface decreases, diffusion capacity decreases, elastic recoil decreases, bronchioles and alveolar ducts dilate, the ability to cough decreases. In the lungs, residual volume increases, vital capacity decreases, efficiency of oxygen and carbon dioxide exchange decreases, the elasticity of lung tissue decreases. Muscle atrophy of the pharynx and larynx occurs. Vocal cords become slack. Laryngeal muscles lose elasticity and airways lose cartilage. Vascular resistance to blood flow through the pulmonary vascular system increases. Pulmonary capillary volumes decreases, so the risk for hypoxia in older adults increases. Exercise tolerance is decreased because of the body's response to hypoxia, and increased levels of carbon dioxide is slower. Respiratory muscle strength, especially the diaphragm and the intercostal muscles, decreases with aging. Effectiveness of the cilia decreases and alveolar macrophages are altered, making the older adult more susceptible to infections. Finally, there are chest wall changes that occur with aging. The anterior diameter increases. The thorax becomes shorter. Chest wall compliance decreases. thus making it more difficult to move gases in and out of the body. Respiratory disease is a major cause of illness and chronic disability in older patients. Although respiratory function normally declines with age, there is usually no problem keeping pace with the demands of ordinary activity. The sedentary older adult, however, often feels breathless during exercise. It is difficult to determine which respiratory changes in older adults are related to normal aging and which changes are caused by respiratory or exposure to pollutants. Age-related changes in the muscles and the cardiac and vascular system also may cause abnormal breathing, even if lungs are normal. Obtaining accurate information from the patient is important for identifying the type and severity of breathing problems. Age, gender, and race can affect the physical and diagnostic findings related to breathing. Explore the home, community, and workplace for environmental factors that could cause or worsen lung disease. Ask about home conditions such as the type of heat used, either a gas heater, wood-burning stove, fireplace, or kerosene heater. Determine exposure to irritants. Ask about hobbies such as painting, working with ceramics, building model airplanes, refinishing furniture, or woodworking, which may expose the patient to harmful chemicals. Ask patients about their respiratory history, including smoking history, drug use, travel, and area of residence. Smoking history includes the use of cigarettes, cigars, pipe tobacco, and marijuana, and other controlled substances. Ask whether any of these substances are now or in the past been used. If the patient smokes, ask for how long, how many packs a day, and whether he or she has quit smoking and how long ago. Document the smoking history in pack years, which is the number of packs smoked per day multiplied by the number of years the patient smoked. Smoking induces changes in the airways that leads to some airway obstruction. As a result, smokers have a more rapid age-related decline in pulmonary function than do non-smokers. Drug use, both prescribed drugs and illicit drugs, can affect lung function. Some drugs affect the lungs when taken systemically. Ask about drugs taken for breathing problems and about drugs taken for other conditions. For example, a cough can be a side effect of some antihypertensive drugs, ACE inhibitors. Determine what over-the-counter drugs, including cough syrups, antihistamines, decongestants, inhalants, nasal sprays the patient uses. Allergies to substances such as food, dust, mold, pollen, bee stings, trees, grass, animal dander, or drugs can affect breathing. If the patient has received treatment for allergies, ask about what caused the need for treatment, the type of treatment, and the response to treatment. Travel and geographic area of residence may be relevant for possible exposure to certain diseases. For example, histoplasmosis, a fungal disease caused by inhalation of contaminated dust, is found in the central part of the United States and Canada. Coccidiomycosis, better known here as valley fever, is another fungal disease, found mostly in the western and southwestern parts of the United States, in Mexico, and in portions of Central America. Assess the patient's diet history and nutrition status to determine allergic reactions to certain foods or preservatives. Manifestations range from rhinitis, chest tightness, weakness, dyspnea, urticaria, and severe wheezing to loss of consciousness. Obtain a family history to assess for respiratory disorders that have a genetic component, such as cystic fibrosis, some lung cancers, and emphysema. Patients with asthma often have a family history of allergies. Whether the breathing problem is acute or chronic, the current health problem usually includes cough, sputum production, chest pain, and shortness of breath at rest or on exertion. Cough is a sign of lung disease. Ask the patient how long the cough has been present and whether it occurs at a specific time of day or in relation to any physical activity. Ask whether the cough produces sputum or is dry, tickling, or hacking. Sputum production is an important symptom associated with coughing. Check the duration, color, consistency, odor with coughing. Sputum may be clear, white, tan, gray, or, if infection is present, yellow or green. Describe the consistency of sputum as thin, thick, watery, or frothy. Hemoptysis, blood in the sputum, is most often seen in patients with chronic bronchitis or lung cancer. Ask the patient to quantify the sputum by describing its volume in terms such as teaspoon, tablespoon, and cups or fraction of cups. Normally, the bronchial tree can produce up to 3 ounces, 90 milliliters of sputum per day. Chest pain can occur with other health problems as well as with lung problems. A detailed description of chest pain helps distinguish whether it is caused by pleural, musculoskeletal, cardiac, or gastrointestinal problems. Ask the patient whether the pain is continuous or made worse by coughing, deep breathing, or swallowing. Cardiac pain is usually intense and crushing. It may radiate to the arm, shoulder, or neck. Pulmonary pain varies depending on the cause. Pain that feels like something is rubbing inside is more common with pulmonary pain. Dyspnea, difficulty in breathing or breathlessness, is a subjective perception and varies among patients. A patient's feeling of dyspnea may not be consistent with the severity of the problem. Determine the type of onset, slow or abrupt, the duration, number of hours, time of day, relieving factors, position changes, drug use, activity sensation, and whether wheezing, crackles, or stridor occurs with the breathlessness. Ask about paroxysmal nocturia dyspnea, PND, which is intermittent dyspnea during sleep, and about orthopnea, which is shortness of breath that occurs when lying down but is relieved by sitting up. These two conditions often occur with chronic lung disease and left-sided heart failure. In paroxysmal nocturnal dyspnea, the patient has a sudden onset of breathing difficulty that is severe enough to awaken him or her at night. Inspect the patient's external nose for deformities or tumors, and inspect the nares for symmetry of size and shape. Use your pen light, the interior of each nares, by asking the patient to tilt their head back. Inspect for color, swelling, and drainage and bleeding. The mucous membranes of the nose normally appear redder than the oral mucosa, but it is pale, engorged, and bluish-gray in patients with allergic rhinitis. Check the nasal septum for bleeding, perforation, or deviation. Septal deviation is common and appears as an S shape tilting toward one side or the other. Nasal polyps, a common cause of obstruction, are pale, shiny, gelatinous lumps of bags attached to the tuberance. Block one nares at a time to check whether air moves through unblocked side easily. Assessment of the pharynx begins with inspection of the mouth. To examine the posterior pharynx, use a tongue depressor to press down one side of the tongue at a time to avoid stimulating the gag reflex. As the patient says "ah," observe the rise and fall of the soft palate and uvula and inspect for color and symmetry, drainage, edema, or ulceration, and enlarged or inflamed tonsils. Inspect the neck for symmetry, alignment, masses, swelling, and bruises, and the use of accessory neck muscles in breathing. Palpate lymph nodes for size, shape, and mobility, consistency, and tenderness. Tender nodes that are movable suggest inflammation. Malignant nodes are often hard and do not move with palpation. Gently palpate the trachea for position, mobility, tenderness, and masses. The trachea should be in the midline. Many lung disorders cause the trachea to deviate from the midline. The larynx is usually examined by a specialist with a laryngoscope. An abnormal voice, especially hoarseness, may be heard when there are problems of the larynx. Inspect the front and back of the thorax with the patient sitting up. The patient should be undressed to the waist and draped for privacy and warmth. Observe the chest and compare one side with the other. Work from the top and move downward toward the base, going from side to side while inspecting for discoloration, scars, lesions, masses, and spinal curvatures. Assessing from side to side allows you to compare the assessment findings from each lung at the same level. Observe the rate, rhythm, and depth of inspiration as well as symmetry of chest movement. Impaired movement or unequal expansion may indicate disease. Observe the type of breathing, pursed-lipped or diaphragmatic breathing, and the use of accessory muscles during breathing. Examine the shape of the patient's chest and compare the anterior-posterior or AP or front-to-back diameter with the lateral or side-to-side diameter. The ratio normally is about 1 to 1.5 depending on body build. The ratio increases to 1 to 1 in patients with emphysema, which results in the typical barrel chest appearance. Normally the ribs slope downward. Patients with air trapping in the lungs caused by emphysema have ribs that are horizontal. Observe or palpate the distance is usually 1 finger's breadth or 2 centimeters. The distance increases in disorders that cause air trapping such as emphysema. Observe for retraction of muscles between the ribs and at the sternal notch. Retractions are areas that get sucked inward when the patient inhales. Palpate the chest after inspection to assess respiratory movement, symmetry, and observable abnormalities. Palpate abnormalities found on inspection, such as lesions, bruises, and swelling. Also palpate for tenderness, particularly if the patient has reported pain. Crepitus, which is air trapped in and under the skin, also known as subcutaneous emphysema, is felt as a crackling sensation beneath the fingertips. Begin auscultation with the patient sitting in an upright position. With the stethoscope pressed firmly against the chest wall, instruct the patient to breathe slowly and deeply through an open mouth. Use a systematic approach beginning at the lung apices and moving from side to side down through the intercostal spaces to the lung bases. This side-to-side method allows you to compare one lung with the other at the same level. Normal breath sounds are produced as air vibrates while moving through the passages from the larynx to the alveoli. Normal breath sounds are known as bronchial or tubular. They are harsh, hollow sounds heard over the trachea and main stem bronchi. Bronchovesicular, heard over the branching bronchi, and vesicular, soft rustling sound heard in the periphery over small bronchioles, are normal and should be described or documented as normal, increased, diminished, or absent. Advantageous sounds are additional breath sounds superimposed on normal sounds, and they indicate pathologic changes in the lung. Advantageous sounds include crackles, wheezes, rhonchi, and pleural friction rub. Advantageous sounds vary in pitch, intensity, duration, and the phase of respiratory cycle in which they occur. Fine crackles, fine or high-pitched rails occur during inspiration. They are characterized by a popping, discontinuous sound caused by air moving into previously deflated airways. They sound like hair being rolled between the fingers near the ear. Coarse or low-pitched crackles are more common on expiration, but also can be heard during early inspiration. They are characterized as low-pitched, coarse, rattling sounds caused by fluid or secretions in large airways. Crackles are likely to change with cough or suctioning. Wheezes are audible during both inspiration, expiration, or both. Wheezes sound squeaky, musical, continuous sounds associated with air rushing through narrowed airways. They may be heard without a stethoscope. Wheezes usually don't clear with coughing. Rhonchi are audible during both inspiration and expiration, but are commonly more prominent on expiration. Rails are low-pitched, coarse, continuous snoring sounds. A pleural friction rub are heard during both inspiration and expiration, generally at the end of inspiration and the beginning of expiration. A pleural friction rub is loud, rough, grating, scratching sounds caused by the inflamed surfaces of the pleura rubbing together. It is often associated with pain on deep inspiration. Assess other indicators of respiratory adequacy because gas exchange affects all body systems. Some manifestations, like cyanosis, indicate immediate oxygenation problems. Other changes, like clubbing of the fingers and toes and weight loss, reflect long-term oxygenation problems. Skin and mucous membrane changes, such as pallor or cyanosis, may indicate inadequate oxygenation. Assess the nail beds and mucous membranes of the mouth. Arms and legs may appear thin or lack muscle, especially with COPD patients. Endurance decreases whenever breathing is inadequate for gas exchange. Observe how easily the patient moves and whether he or she is short of breath while resting or becomes short of breath while walking 10 to 20 steps. As the patient speaks, note how often he or she pauses for breath between words. Breathing problems from any cause often induces anxiety. The patient may be anxious because of reduced oxygen to the brain or because of the sensation of not getting enough air is frightening. The thought of having a serious respiratory problem, such as lung cancer, can also induce anxiety. Encourage the patient to express his or her feelings and fears about manifestations and their possible meaning. Chronic respiratory disease may cause changes in family roles or relationships, social isolation, financial problems, and unemployment or disability. Discuss coping mechanisms to assess the patient's reaction to these stressors and identify strengths. Assist the patient in determining available support systems to help cope with changes resulting from breathing problems. There are several laboratory tests used to diagnose and assess for respiratory problems. A RBC count provides data about the transport of oxygen. Hemoglobin transports oxygen to the tissues. A deficiency of hemoglobin could cause hypoxemia. ABGs assess oxygenation, alveolar ventilation, and acid-base balance. Blood gas studies provide information for monitoring treatment results, adjusting oxygen therapy, and evaluating the patient's responses to therapy. Sputum specimens can help identify organisms or abnormal cells such as cancer or an allergy. Sputum culture and sensitivity analysis identify bacteria infections and determine which specific antibiotics will be most effective. Sputum cytological examinations can identify cancer cells as well as non-cancerous conditions such as allergy or autoimmunity. Chest x-rays with digital images are used for patients with pulmonary problems to evaluate the status of the chest and to provide a baseline for comparison with future changes. Chest x-ray are used to assess pathological changes in the lungs, such as with pneumonia, atelectasis, pneumothorax, which is a collapsed lung, and tumors. The x-ray also can detect detect pleural fluid imposition and placement of an endotracheal tube or other invasive catheters. Sinus and facial x-rays are used to assess fluid levels in the sinus cavity to assist in the diagnosis of acute and chronic sinusitis. Computer tomography, or CT, is useful when an x-ray reveals suspicious lesions or when clot is suspected, because pulmonary soft tissue densities, tumor and blood clots can be seen. Usually CT scan requires a contrast agent injected IV. The contrast enhances the visibility of structures such as tumors, blood vessels, and chambers of the heart. Pulse oximetry identifies hemoglobin saturation. Usually hemoglobin is almost 100% saturated with oxygen. Pulse oximetry can detect desaturation before manifestations such as skin, mucous membranes, and male bed changes occur. Results lower than 91% and certainly below 86% are an emergency and require immediate assessment and treatment. When oximetry readings are below 85%, body tissues have a difficult time becoming oxygenated. Below 70% is usually life-threatening, but in some cases values below 80% may be life-threatening. Capnometry and capnography are methods to measure the amount of carbon dioxide present in exhaled air, which is an indirect measurement of arterial carbon dioxide levels. These non-invasive tests measure end-tidal carbon dioxide levels in both intubated patients and those breathing spontaneously. With capnometry, the exhaled air sample is tested with a sensor that changes its CO2 level into a color or number for analysis. With capnography, the CO2 level is graphed as a specific waveform along with a number. These methods provide information about CO2 production, pulmonary perfusion, alveolar ventilation, respiratory patterns, ventilator effectiveness, and possible rebreathing of exhaled air. The normal pressure end-tidal carbon dioxide ranges between 20 and 40 millimeters of mercury, just slightly lower than the normal range of arterial PaCO2. Changes in PET CO2 reflect changes in breathing effectiveness and may occur before hypoxemia can be detected using pulse oximetry. Pulmonary function tests evaluate lung function and breathing problems. These tests include lung volumes and capacities, flow rates, diffusion capacity, gas exchange, airway resistance, and distribution of ventilation. The results are interpreted by comparing the patient's data with expected findings for age, gender, race, height, weight, and smoking status. The PFTs are useful in screening patients for lung disease even before the onset of manifestations. Serial testing, or repeated over time, provides objective data that may be used as a guide for treatment. Exercise increases metabolism and increases gas transport because energy is used. Exercise testing assesses the patient's ability to work and perform ADLs, differentiates reasons for exercise limitations, evaluates disease influence on exercise capacity, and determines whether supplemental oxygen is needed during exercise. These tests are performed on a treadmill or bicycle or by a self-paced 12-minute walking test. The normal patient's exercise is limited by circulatory factors, whereas the pulmonary patient is limited by breathing capacity, gas exchange compromise, or both. Skin tests are used with other diagnostic data to identify various infectious diseases such as tuberculosis, viral infections such as mononucleosis, or mumps, and fungal diseases such as coccidiomycosis, again, valley fever. Allergies and the status of the immune system also can be checked through skin testing. Exposure to allergens or organisms used in testing produces a specific reaction, a delayed hypersensitivity type 1 reaction. Endoscopic studies to assess breathing problems include bronchoscopy, laryngoscopy, and mediastinoscopy. With laryngoscopy or scopy, a tube for visualization is inserted into the larynx to assess the function of vocal cords, remove foreign bodies caught in the larynx, or obtain tissue samples for biopsy or culture. A mediastinoscopy is the insertion of a flexible tube through the chest wall just above the sternum into the area of the upper chest between the lungs. This procedure is performed in the operating room with the patient under general anesthesia to examine local structures for the presence of tumors and to obtain tissue samples for biopsy or culture. Most complications are related to anesthetic agents and bleeding in this procedure. The most common procedure is the bronchoscopy. A bronchoscopy is the insertion of a tube in the airways, usually as far as the secondary bronchi, for the purpose of viewing airway structures and obtaining tissue samples for biopsy or culture. It is used to diagnose and manage pulmonary diseases. Bronchoscopy is often used for lung cancer staging and removal of secretions that are not cleared with normal suctioning procedures. Stents can be placed during bronchoscopies to open strictures in the trachea and bronchus. The patient should be NPO for at least 4 hours before the procedure to reduce risk of aspiration. Pre-medication may be used to provide both sedation and amnesia. Opiates may be used. Nursing responsibilities after the procedure include monitoring the patient until the effects of the sedation have worn off and gag reflex has returned. Continue to monitor the patient's vital signs, including oxygen saturation, and assess breath sounds every 15 minutes for the first 2 hours. Also assess for potential complications, including bleeding, infection, or hypoxemia. Thoracentesis is the aspiration of pleural fluid or air from the pleural space. It can be used for diagnosis or treatment. Microscopic examination of pleural fluid helps in making a diagnosis. Pleural fluid may be drained to relieve blood vessel or lung compression and the respiratory distress caused by cancer, empyema, which is pus in the lungs, pleurisy, or tuberculosis. Drugs can be instilled into the pleural space during thoracentesis. Patient preparation is essential before thoracentesis to ensure cooperation during the procedure and to prevent complications. Tell the patient to expect a stinging sensation from the local anesthetic agent and a feeling of pressure when the needle is pushed through the tissue of the posterior chest. Stress the importance of not moving during the procedure. The patient should be told to avoid coughing, deep breathing, or sudden movement to avoid puncture of the pleura or lung. This slide shows the best position for a thoracentesis. The position widens the space between the ribs and permits easy access to pleural fluid. Properly position and physically support the patient during the procedure. Use pillows to make the patient comfortable and to provide physical support. Stand in front of the patient to prevent the table from moving and the patient from falling. Thoracentesis is often performed at the bedside by a nurse practitioner or a physician. The short 18 to 25 gauge thoracentesis needle is advanced into the pleural space. Gentle suction is applied as the fluid in the pleural space is slowly aspirated. A vacuum collection bottle is sometimes needed to remove large volumes of fluid. To prevent re-expansion Pulmonary edema, usually no more than 1,000 milliliters of fluid is removed at one time. If pleural biopsy is to be performed, a second larger needle with a cutting edge and a collecting chamber is used after the needle is withdrawn. Pressure is applied to the puncture site and a sterile dressing applied. After thoracentesis, a chest X-ray is performed to rule out possible pneumothorax and mediastinal shift, which is a shift of the central thoracic structures towards one side. Monitor vital signs and auscultate breath sounds for absence or reduced sounds on the affected side. Check the puncture site dressing for leakage or bleeding. Teach the patient about manifestations of pneumothorax, which is a partial or complete collapse of the lung, which can occur within the first 24 hours after a thoracentesis. Manifestations include pain on the affected side that is worse at the end of inhalation and at the end of exhalation, rapid heart rate, rapid shallow respirations, a feeling of air hunger, prominence of the affected side that does not move in and out with respiratory effort, trachea slanted more to the unaffected side instead of being in the center of the neck, new onset of nagging cough, and cyanosis. Instruct the patient to go to the emergency room if any of these manifestations occur. A lung biopsy is performed to obtain tissue for histologic analysis, culture, or cystologic examination. The tissue samples are used to make a definitive diagnosis of cancer, infection, inflammation, or lung disease. There are several types of lung biopsies. The site and extent of the lesion determine which one is used. Transbronchial biopsy and transbronchial needle aspiration are performed through the skin for areas that cannot be reached by bronchoscopy. An open lung biopsy is performed in the operating room. The patient may worry about outcome of the biopsy and may associate the term biopsy with cancer. Explain what to expect before and after the procedure and explore the patient's feelings. Percutaneous lung biopsy is usually performed in the radiology department after an informed consent has been obtained. Fluoroscopy or CT is often used to visualize the area undergoing the biopsy and to guide the procedure. The patient is usually placed in a lying position depending on the location of the lesion. The skin is cleansed with an antiseptic agent and a local anesthetic is given. Under sterile conditions, a spinal type 18 to 22 gauge needle is inserted through the skin into the desired area and tissue needed for microscopic examination is obtained. Apply a dressing after the procedure. A CT or chest X-ray must follow the biopsy to confirm there is no pneumothorax. Monitor the patient's vital signs and breath sounds at least every 4 hours for 24 hours and assess for signs of respiratory distress such as dyspnea, pallor, diaphoresis, and rapid breathing. Pneumothorax is a serious complication of needle biopsy and open lung biopsy. Report reduced or absent breath sounds immediately. Monitor for hemoptysis or frank bleeding from the vascular or lung trauma.